So what is focal therapy? By definition, it is just treating the focus of prostate cancer that is present. This is not a new concept. It's been around in many other cancers for decades. So for example, breast cancer now, it's fairly unusual now for a woman to have to undergo a mastectomy. She will have the lump removed, she might have a little bit of local radiation and so on, but she preserves the organ. Kidney cancer, we do a lot more partial nephrectomies now than we used to and leave the rest of the kidney intact. Thyroid cancer, lung cancer, we're all moving more and more towards a focal approach, trying to preserve the organ. And this should not exclude prostate cancer, and that's what we feel. And that's why we've been trying to develop focal therapy over the last 20 years, not just us, in many other countries and so on. It is now taking hold. And like I said, it treats and destroys the part of the gland containing the cancer. It therefore spares the normal tissue and important structures, such as the nerves, such as the urethra and the urethral sphincter in particular, which controls continence. The side effects, therefore, are reduced, and this has been shown in multiple studies and papers over the years. You do recover very quickly. I do most of my focal therapy treatments as a day procedure under a general anesthetic, and the patient goes home the same day. So therefore, recovery is much, much quicker. There is no radiation involved. Very important to bear that in mind. There is no hormonal treatment involved in standard focal therapy. And also, these treatments can be repeated because there is no radiation. We can repeat HIFU, we can repeat cryotherapy, we can repeat NanoKnife. We can treat the same part of the prostate or a different part of the prostate. And people are monitored very closely after focal therapy to see if there's any recurrence. Equally, if it is required, and the studies suggest only about 5% may require a whole gland treatment in the future. If the patient is selected carefully, the chance of needing a whole gland treatment in the future are between 5 and 10%, and those treatments are not excluded if you've had focal therapy. You obviously have to choose your surgeon carefully, but radical prostatectomy can be performed after focal HIFU treatment, focal NanoKnife and focal cryotherapy, and also radiation can be administered after a focal treatment. So these are the three standard focal therapies which have been evaluated by NICE in particular and are the mainstay. There are newer technologies coming on stream, perhaps laser ablation and so on, but these are the established ones and which have some degree of NICE guidance associated with them. And I've just listed there the NICE guidance if people want to look those up. But high intensity focused ultrasound, cryotherapy, which means freezing the area of the prostate cancer, and IRE, or irreversible electroporation, which is a long word for what is colloquially known as NanoKnife. And I'll come on to that in a moment. What are the selection criteria? And these are what I call the standard selection criteria. These are the ones that we all recognize and try and adhere to. But with experience and so on, there are certain nuances that one can develop around different types of disease. So Gleason score 7 or below is a standard selection criteria. That's now known as ISUP grade group 2 or grade group 3. So it's either Gleason 3+4 or 4+3, or in some cases 3+3 cancer. The PSA has to be ideally less than 20. Ideally, the cancer should be on one side of the gland to limit the side effects primarily. Geographical location and an MRI-visible lesion are also important determining factors. And when patients come to see me through the focal therapy clinic and so on, these are all the considerations that are going through my mind and through our MDT, whereby we decide whether a patient is actually suitable or not. It should not have metastasized, ideally. There is a trial called the Atlanta trial, whereby they are thinking of trying to use focal treatments to the primary. But ideally, the standard selection criteria means that it should be localized and non-metastatic. Previous radiotherapy is not excluded, and we now have data, as Brian alluded to earlier, suggesting that it is almost, well, it is equivalent to a salvage radical prostatectomy. But with far reduced side effects. So previous focal therapy is not excluded. Previous radiotherapy is not excluded.